We do this every Tuesday, but this is a very special Tuesday because this is our fourth Tuesday feature where we have Dr. Brandy Kelly from Louisiana here to talk to us today about mental wellness. Such an important topic. We had Dan Baker on here a few weeks ago talking about this, but Brandy's got a little bit different take on it. And she's got this Clinician's Wellness Toolkit that she's going to talk to us about here shortly. So I'm very anxious to and very thankful to have Brandy here today. Dr. Kelly, thank you so much for being here.
I'm really excited to be here. I told Juanita this is the most fun thing scheduled on my calendar today. So I'm very happy to be here with
I
y'all.
feel honored. I feel honored. And we're going to get to your fun fact here in just a little bit when you introduce yourself. But before we get into that, I am going to give the gavel over to my co-host here, Juanita St. Croix, who is going to. Oh, wait a minute. No, I'm not yet ready to do that. Babs reminded me by shifting the slide. I need to talk about our upcoming schedule on CCN. So on CCM, we've got Tam Ho and Volunteer Behavioral Health next week here, and they're going to talk to us about 811. Then on June 6th, we've got Voice It. June 13th, we're still looking for somebody on June 13th. So if somebody out there has something that they'd like to present on CCN, let us know. We'll try to plug you in if we can. On June 20th, Tennessee Commission on Children and Youth is going to talk to us about their program Kids Central. Then on June 27th, we've got Dr. Wanda Brown Ramser. Babs, you got any information on what Dr. Ramser is going to be presenting on?
Juanita has that, but I want to make one correction. Somehow, it's not 811. The suicide.
Yeah, it's 988.
988. I don't know how I did that.
Because it had been 988 on here several times before, and I
thought it was Juanita's slide.
Okay, so it's 988.
And Juanita has the information.
Okay.
So Dr. Wanda Brown Ramser is from North Carolina, and she's going to be speaking to us about a therapeutic camp she has set up. It's a family camp, and I don't think it's an overnight sleepaway kind of camp. I think what it is intended to be an intense week-long dive into the family's trauma history and how it relates to the person in the family who has an IDD and a dual diagnosis, and how they can kind of pull that apart and look at their individual, their historical trauma and put that in some sort of a context to help the person with the IDD.
Outstanding. We can't get enough on trauma and.
No. Oh, am I frozen?
I can hear you on it.
Oh, it's Bruce. No, we can't. Absolutely. Wellness and trauma, I think.
Those are two topics that are just, we need a lot of repetition on those. So that's really great stuff.
Most definitely.
Okay. So now I think it's time for my co-host here, Juanita St. Croix, who is going to provide today's Get Smart. Oh, actually, she's going to introduce Dr. Kelly first. I'm really on it today. I'm telling you, I'm right with it on everything I'm supposed to be doing. So Juanita, if you want to go ahead and do her introduction and then and launch right into your Smarticle for today.
Absolutely, I will. So I am also honored to have Dr. Kelly here with us today. It's just such a great pleasure. And Dr. Kelly received her doctoral degree in clinical psychology from Louisiana State University in 1998, postdoctoral master's degree in clinical psychopharmacology at Alliant University in 2002. She has worked extensively providing person-centered and wellness-focused support, planning and behavioral health services to people with developmental disabilities, and has published research on assessment and treatment of behavioral health concerns of people with developmental disabilities. Dr. Kelly has been instrumental in key initiatives in Louisiana to increase capacity to support individuals with co-occurring needs to live and work in their communities while navigating the logistics of fiscal resource challenges in partnership with self-advocates, advocacy organizations, providers, and other state agencies. She received the Bernard R. Wagner Leadership in Developmental Disabilities Award, special recognition for enhancing the wellness of individuals with IDD from the ARC of Louisiana, and currently sits on the National Association for Dual Diagnosis Continuing Education Conference Committee. Dr. Kelly is a published author of several books and chapter contributions identifying effective supports and strategies for supporting people who have an IDD. Her most recent publication will be available this month. From now, there's a little pump for it. It's called The Good Stuff, edited by Dr. Uzama Price and Dr. Dan Baker. And I believe she's going to give us a little glimpse of what she has authored in that chapter today. So we will get back to Brandy in a minute while I take a look at our Smarticle, which still cracks me up. Like one of these days, I'm going to come dressed as 99. For those of you old enough to know that reference.
Yeah, this is, I would say that this is a 61-year-old reference, you know.
But
So
that's
perfectly appropriate for me. Actually, I think he might have been Maxwell Smart, that Get Smart was probably a show in the late 60s. I'm 61, so only a 61-year-old would come up with this as a reference, probably. But anyway,
I think it's fantastic. Anyway, so Dr. Kelly has provided an article for us to take a quick look at today that relates to her discussion, and that article is Character Strength Activation for People with Intellectual and Developmental Disabilities Using Video Feedback in Groups. It's authored by Andrea Zucks, Carolyn Chow, Kiera Mascara, and Dan Tomasulo. And the citation for anyone interested in finding it is listed below, which will then obviously be visible on the taped video recording that I believe sits with the state of Tennessee. And it is published in the Journal of Education and Learning. So in this article, the authors reviewed theory, research, applied aspects, and future possibilities using strength-based positive interventions in action, obviously modified for people with no or low literacy with the use of camera and video feedback. I think this is not a great surprise to anybody. Positive interventions are vehicles to focus on what's strong instead of what's wrong. They're designed to advance human flourishing. By making different types of positive interventions more accessible for people who have an IDD, it would have an extremely beneficial impact on helping people increase their overall wellness. So what did they do? They did a literature review, first of all. So, and again, defined what positive interventions are intended to do, focus on the strengths as opposed to what's wrong. The discovery through all the literature search was that people who have an IDD are among the most marginalized and stigmatized people, with a lack of inclusion in research, something we discussed in great detail with Dr. Tim Barksdale a couple of weeks ago as well. And there is a notable absence of providing interventions other than ABA with people who have an intellectual developmental disability. So the disparity in the use of effective interventions for those with an IDD or a dual diagnosis is particularly wide when it comes to the application of evidence-based positive interventions, such as DBT. Video feedback. So what they did, they used cameras in social skill building and behavior modification sessions, along with teaching job tasks and enhancing employment skills. Some of the literature indicates that the use of cameras and video feedback for participants to address and explore their social behavior and the behavior of others was particularly effective. It facilitates a sense of community, enhances interpersonal awareness, and improves social interactions. They offer the same benefits for people with an IDD as they would with a typical group. So the paper is inviting the reader to consider new ways to use role modeling and in strength-based practices and with the use of video camera feedback. So Dr. Tomasulo and Dr. Zucks in 2015 developed the acting cure, I believe is the concept that they work on. It's an interactive behavioral therapy model, and it was used to illustrate the impact of video feedback. It did a comparison between groups, comparison of groups run separately, one with the use of video feedback and one with the use without. So one in application without video feedback. The people who were in the study with the video feedback were able to see the best possible version of themselves right there on the TV screen. And there hear the honest feedback, praise, suggestions for growth from other group members. What it did was reinforce those identified strengths that they were working to build on. So the video feedback of dramatic events of stories and past and current successes and role-playing a future best self, they theorize may foster the activation and use of character strengths for people who have an IDD, indeed for all people. Conclusion, by building on existing individual strengths and applying them in their daily lives, people with an IDD may find greater opportunities to pursue their goals and develop fuller, stronger sense of self. Using video feedback can open the door for new possibilities, moving towards role models coming from within by activating character strengths. Absolute ideal situation. Further research is needed, as suggested, and noteworthy to explore full noteworthy benefits of such practices and to collect data to establish best possible uses and maximize benefits from such practices. And I believe that's all I had to say, although there were some really cool charts I wanted to copy and paste into that. I figured they were just for me, so I pasted them into my own copy. Anyway, that brings us to Dr. Brandy Kelly. I'm so delighted you're here with us today. Please share with us something that maybe not many people know about you.
Okay, well, I jokingly told Bruce, Babs, and Juanita that I don't always conceptualize myself as fun when they ask me to come up with a fun fact, and that maybe that is an inkling that I need to take a look at my own wellness, right, and how I see myself. But I guess I will share that prior to my journey to becoming a psychologist and doing the work that I do today, I spent the first 21 years of my life as a dancer. I danced and I taught. I was Miss Drill Team Louisiana. And if it weren't for my dad insisting that I do something practical, I probably would be, I don't know, dancing somewhere in New York today, because that's what I really thought I wanted to do. But instead, I embarked on this pathway, and here I am with you today.
Oh my God, Bruce and I have identical facial expressions right now.
Jaw dropping. That's all that can be said. Wow. Okay. What kind of dancing do you do, Dr. Kelly?
Jazz, tap, ballet, contemporary. I mean, just a regular dance studio kind of dancing. Back before there was a lot of specialization, we had to learn everything, right? Like now kids can say, I don't like that ballet stuff and I don't want to do it. And the lady I took from is who I taught from. I started at the age of 2. She is still dancing today. So, and my niece actually is finishing her final year at her dance studio. So,
that's amazing. How did you find your way from that into what you're doing now? That's the next question we'll have to ask.
I always was a great student, and my father insisted that I had to go get my college degree and do something, practical. And I did always enjoy psychology. I took a couple of electives in high school when they let you. So I always knew that it was something I wanted to do. The irony, so I studied at LSU, and of course, for those of you who've been around a long time, Dr. Matson was there. I did not enter the program working with him. In fact, to make the story funnier, I have a sister who has a disability. And so I purposely did not go to work for Johnny or apply to work for him, because I thought, I've lived this my whole life, right? That's not what I want to do every day. They require us to do what they call an off year. So you have to work with another professor. And so I thought, okay, well, maybe I'll work with Johnny for that year. Well, that happened to be the year that the Department of Justice was coming in to look at Pinecrest, one of the state facilities that we operated. So I got a phone call from Johnny about a week before the Christmas holidays that he was going up there and he could take 3 students with him. And it was funny because even though I wasn't one of his students, I lived in Louisiana, right? So he knew I'd be around for the holidays. So he asked if I wanted to go. We were supposed to be there for 3 weeks. Our running joke was we never left. But the experience in doing that, it honestly really sort of felt like coming home. I mean, he said he joked with his students that they had a running bet as to how soon I would switch. And I did, and I've been doing this work ever since.
So for those who may not know who you're talking about, Dr. Johnny Matson has done tons of research for people with intellectual and developmental disabilities, and was also the author, I believe I'm correct, of an instrument called the PIMRA Psychopathology Inventory for Mentally. Well, it was an older term that we used, but it was an instrument that he created. And so
Yes.
was among the first people, like many of the people in our NAD organization, who really started this idea that people with IDD might have a co-occurring mental health disorder.
Mhm.
Yeah, my very first NAD meeting was actually the year I think Johnny got the Frank Mendelacino Award. So yeah.
Yeah, yeah,
Wow.
great guy. And so you're one of his students.
I am.
That's great.
Okay, I'm only going to take 30 seconds on this so we can get to Brandy's topic, but I'm of course thinking Brandy is here on our NAD conference committee. We're trying to plan some kind of a little dance lesson for one of our nights while we're in Tennessee.
I am from,
Leave.
yeah.
Yes.
I know Juanita's gonna rope me into something. Did I mention I don't like a lot of attention despite the fact that I dance? That may be funny, but I don't know, Juanita. We'll have to talk about that. I might be able to help you out. I do know a little bit. I do know my fair share of line dances since I've, grown up in the
Oh,
South. So
yes, yes, you're definitely hired.
If we can get some other people who do not like to be the center of attention to do this with you, then maybe it'll be
yeah,
fun.
sure. Once we get started, I won't care.
Of course. Oh, marvelous.
Yeah,
Okay.
it'll be fun. We'll have fun. It's the 40th anniversary. We have to have fun. So.
We
That's
do.
right. That's right.
They do. So, wow, thank you for that really interesting
That,
fact that
that
you
was
do
a
not.
very interesting fact. You were sitting here saying you're boring. My goodness, that's amazing.
Yeah,
Thank you.
definitely.
Well, with that, we'll turn it over to you. But before we do, I want to remind everybody, if you have questions or comments, please put them in the chat box. We'll get to them as we can. And if you want to raise your hand, we'll acknowledge you and let you come off and ask a question directly or make a comment directly. So please do that. And with that, I'll turn it over to you, Dr. Kelly.
All right, for a minute, I lost everybody. That's the only thing about sharing your screen, huh? It's like, all right. Well, I am really excited to be here with everybody today. As I shared, this is definitely going to be my most fun hour of the day. So I'm very thankful for the invitation to join you. I am excited about the book that Juanita mentioned. I was honored enough to get to actually co-write that chapter with Dr. Baker, who is on with us today, and Dr. Greer, one of my colleagues here in Louisiana. And I know that Dr. Baker talked with you guys some in general about wellness and wellness models and all of the important wellness areas that we need to pay attention to. And so what I hope I can do today is give you literally some tools that we are beginning to use here in Louisiana that we are seeing some good positive impacts on. And hopefully you'll see these tools really can help you not only as a clinician, sort of when you are working directly with someone, but also in the role that we play often, which is supporting the family and the supporters of people with disabilities so that they are helping that person have a well life. They're not unintentionally getting in the way, right? Because we know they're not intending to do that most of the time. And also that we are being mindful of how often are we helping the person become as independent as possible in meeting their own wellness needs so that they are less dependent on their family, any supporters they have, and those of us who may be providing any specific treatment for them. The article that Juanita shared, so I love Dr. Tomasulo's work. I use it a lot in what I do. It blends very well with all of the wellness considerations. And really, I think challenges us as clinicians to think a little bit differently about how we approach things. And so there's a lot of emerging research to show that, a lot of the traditional mental health tools that we've all used, they really focus on the relief of distress, which is an important part of what we do, but it doesn't address how do we promote well-being, right? And so these positive psychology practices, this focus on strength-based focus and really building strengths, identifying those strengths, that is so that we can be more well, not just not sad, not anxious, etc. And I thought it was fascinating the first time that I was able to listen to a presentation that he gave that they shared that a lot of these positive psychology practices, they come out of looking at people who have depression, who improve after some treatment and don't relapse. So 80% of folks with depression relapse. And a lot of times we study the folks who are struggling, and the folks who are really diving into these positive psychology practices, they said, hey, what about the 20% of people who don't relapse, right? And what they really found is that these folks had more well-being, right? All these things we think of in these wellness categories really characterize these individuals. And so that's why you see a lot of focus in things like, identifying strengths and how do you actually activate those strengths, which was talked about in the article. Relationships, all the things that we know that are important, but are we really paying attention to them, right? And wellness is really like the foundation of anything that we do. And so even as clinicians, if wellness is absent, it really doesn't matter how effective our treatment could be. Any gains we make with that person are not going to be sustained, right? Because they're going back into a life and a day that is really not going to be something that is going to be joyful for them, is going to promote any positive change for them. And so we know that for people with or without IDD, whenever wellness is present, we are healthier physically, emotionally, even things like our mobility, right? Things you think are you don't think of as being as flexible to change, right? There's literally studies that show that folks who really, really engage in wellness practices, they're more mobile, they're more flexible, they can move around life more, and people tend to live longer, right? And the opposite of that happens when wellness is not present. And so we really want to look at how do we build this into more of what we do. So one of the things that we've started doing.
Dr. Kelly, let me ask you a quick question
Yes.
here,
Mhm.
because you mentioned that so 80% of people with depression relapse. So initially they may have gotten some relief by taking some medication or something of that nature, but if they did not have these wellness practices in place, they were most likely to relapse, and that affected
Yes.
80% of the sample that you're referring to.
Yes. Yes.
Okay. Just wanted to make sure I clearly understood that. So really, even if you take some medication to treat whatever mental health disorder you have, you've got to move to this next level to sustain that over the course of time.
Absolutely. Yeah. When you look at this, the research, when those things are absent, folks are either they may leave therapy, but then they go back, right? They may experience some improvements initially with meds, but they're going to have repeat episodes. All of those things that you just mentioned. Absolutely. But when they really looked at what defined that 20% that didn't relapse, it was a lot of wellness practices. And I'm going to get in a little bit more to kind of some of the specifics. Hopefully with one of the tools I'll be able to share, but yes, that's exactly what they found. So one of the things that we've kind of been asking ourselves, and I say we, my team and I, is how do we take what we've sort of traditionally, there's such a focus on terms like positive behavior supports. And there was the mention in the article about most people getting ABA, and how do we get broader than that, right? So we see a lot of triangles like this when people talk about PBS models. But you'll notice in my triangle, I don't use the words positive behavior supports, right? So the bottom rung of the triangle is emotional wellness, trauma-informed care, and person-centered practices built into the foundation of support. then what we should do is help people be as independent as they can and have the skills that they need so that they can do things for themselves and have the life they want. When people start having problems, the first thing we should do is check the first two rungs of the ladder, right? Which doesn't always happen. And so sometimes we get people in our offices or, calling us for help. And so as clinicians, what we want to do is also check those other rungs of the ladder, right? So before we start treating, right, in the more traditional sense, before we start assuming people need medication, et cetera, we need to be sure that the foundation is there and that we are helping people figure out if the foundation is cracked and how they might fix that. If problems continue, then sometimes we do need to do more. And what we can do as clinicians is then think about how do we make recommendations that consider both the wellness aspects in someone's life as well as any formal treatment we think they may need. And then understanding that there are times that people will have enough support around them that those people are going to need written guidance. You will notice I did not call that a behavior plan, right? There are times that that ABA-based treatment may be appropriate for whatever challenges the person is experiencing or maybe even preferred by the individual and their family. And it may be something that is a more formal plan. But even when we are doing therapy with people, even when we're doing positive psychology-based work, if someone needs help every day, the people who are helping them still may need instructions on sort of what to do, what not to do. And so we are working in Louisiana on not calling that a behavior plan because it implies that this is some sort of a formal intervention that the supporters are doing for the person. And so the person will change. And instead what this is really how do you support the person to have the wellness they need in their life? How do you not unintentionally get in the way? And then if they are getting formal therapy, if there are things they're supposed to be practicing, how do you help them practice that, right? When do you do that? So it's really sort of shifting those, the focus there and making sure it also makes it more accessible. The more we talk differently about these things, the more that we are likely to leave families and supporters prepared to be able to do what they need to do to help the person in their wellness activities when we leave. We don't want wellness to be seen as something you need a clinician for, right? We want wellness to be present whether we are there or not. And so I think that that is something that sometimes it sounds, I tell my staff all the time, I feel like I'm the word police, right? Right? Because I'm like, don't call it that or don't say that. And it can seem like it's a technicality, but words matter. And so I find that when we use certain terminology that makes people think something is clinical in nature or treatment related, they think they don't have permission to do it without us, right? And so that is why we have really, really worked on that. And so sometimes when people see this triangle, they'll go, yeah, that's PBS. And I'll say, no, I mean, this is life, right? This is how we support wellness. And yes, if you practice PBS as an approach, if you use applied behavior analysis as a treatment modality, you can still do that within the context of this. Yeah. But I don't want folks to think that to provide wellness for people and like those lower rungs are somehow part of a behavior support model. It's what we all need in life. And if we're honest, we all get support, right? It's just the amount of support we get. We all rely on the people in our lives, the relationships we have. Some things we're better at than others, right? Sometimes we ask for support. And so it's kind of trying to shift to that way of thinking. As the foundation.
That makes sense. I like the way that you're not isolating that to positive behavior supports. That's one mechanism for getting there. I always used to say, because I am a psych examiner and a licensed professional counselor, but also have been licensed as a behavior analyst. And I often use the term, often say, going back to my Nashville roots here, I was positive before positive was cool. I think I employed a positive behavior supports model before we started talking about a positive behavior supports model, but it's clearly it can cut across any profession really that we all should operate based on this foundation that you've laid out here.
Yeah, and we found that it sometimes stops people from being able, even when they do need formal treatment, some of that terminology, it makes people think someone needs, like ABA is the only option. And that may or may not be what someone would benefit from, and it may or may not be what they want. So kind of like what Dr. Sooks and Dr. Tomasulo and colleagues said, it's like applied behavior analysis is a legit form of treatment that works for some people, right? But it's one among many strategies and the continuum of options. So you're right, Bruce, any of us, no matter what treatment modality we're using, no matter what approach we're doing, we want to sort of have this as the foundation. And so we don't want it to be seen as being only associated with a particular model, in addition to not having it be seen as being overly clinical. So one of the things that we've developed in Louisiana is we have a wellness guide. The wellness guide is an available attachment for the waiver plans that we develop for people, but we've also shared it widely with families and other providers. And one of the things that we did during the pandemic was we looked at how does wellness change when people are under some sort of stress? And so certainly as clinicians, that is something we need to look at. And so what I've shared with you here on the screen and you will have access to is just some tips that we can think of where when we are working with individuals and we do encounter them in any of our practices, how do we make sure wellness doesn't disappear when problems happen? Because a lot of times when people are not doing well, either physically or emotionally or in some other way, people think this stuff has to wait, right? And in fact, we kind of can't withstand the challenges in life when wellness is absent. Right? It's a necessity. It actually becomes more important, not less important. And so we gave, and I think it's still on our website, so I'm happy to share it with you, Bruce. There's a little bit more detail of what we did, but this is sort of a summary of how we looked at, where do certain things become even more important? So like enjoyable activities, like finding some things that person can do that are just enjoyable for them actually becomes more important in a crisis. This is really a non-negotiable, right? We gave tips for if somebody can't go out and about for one reason or another, which was prevalent during the pandemic, how do you make sure you access virtual resources and you use some creativity there? How do you make sure that the things that make the person feel really good, so kind of playing into that sort of knowing someone's strengths and what matters the most to them, so they have some sense of control and mastery, even whenever things are really, really difficult. How do you make sure people are still, treating themselves in small ways? How do you practice mini gratitude? How do we make sure people have opportunities for creative expression, to move around? Basics of self-care. Are we getting enough sleep? Are we doing the things that relax us the most, right? Are we getting outdoors in nature where we can? And then how do you shift goals? So how do we understand that people's big goals may halt when things are unstable, whether it's an internal instability in terms of a mental health episode, or whether it is something happening outside of you like we experienced during the pandemic. But there are small things that people can do. And in the midst of the pandemic, we also had a record storm season in Louisiana. And so many of our folks also were impacted by that. And we worked with people to think about things like if things feel out of control and people feel depressed, like how do you help them look at one small thing they could do today, right? Well, maybe my work goals are on hold, but I can go, help my neighbor clean his yard, and I can feel good about that. I can have contact. I can do something that. So it's really sort of taking, these wellness areas and remembering that they don't go out the window even when things are stressful. And so we have both the basic wellness guide, and then we have an adaptable guide. And I'm going to give you guys a QR code at the end. You will have access to both of those as well. So we really have started working on this. We began our wellness guide during a project we did with our DD Council. We worked with 4 providers in the state of Louisiana, and we asked them to identify for us the 5 to 6 individuals they were struggling with the most. And one of the reasons we built the wellness guide during that was because what we found was most of those people just didn't have a life. They really didn't need therapy. In fact, only 30% of the individuals, now it was a small sample, right? But only 30% of the individuals that they identified for us across all 4 providers did we actually connect to formal therapy of any kind. With the rest of them, we worked with them to learn more about what mattered to them. We built a wellness guide for them. We worked with their provider and we worked with their staff. And what we saw with every single one of them, without fail, was that not only did their emotional and behavioral reactions that were a struggle or the challenge decrease, their relationships improved. Not just in the way of meeting new people, but their families were able to sort of spend time with them and report positive experiences doing that. We had people working towards getting a job. We had some folks who actually had a reduction in support hours, right? They actually began to learn some new skills. Their staff got more comfortable with that. And because they weren't having the challenges they were having, they actually had less support hours from staff. We use that as a jumping board to bring it into our waiver program. We also piloted the adapted wellness guide that you see here with some of our resource center staff. Those are the state clinicians that we employ during the pandemic. And they were able to work with some individuals that they had previously done direct treatment with who started to have some challenges during the pandemic. And without seeing them in person, they did this all via telehealth. They took what they knew about that person and what was most important to them and helped their family and staff build an adapted wellness guide and use it during the pandemic. Every one of those people was able to stabilize out with those brief telehealth booster sessions, no formal therapy at all. And then we most recently piloted with a provider who had come to us asking for help because he said they were waiting to see professionals, right? They thought these people needed treatment. And so this was one of the tools we used with them. And for the 8 individuals that they worked with, all of them had improved relationships. They were more engaged with activities and work during the day, and they had decreased emotional and behavioral reactions. So that doesn't mean some of them may not still need formal treatment, right? But we were able to give them a tool they could implement immediately with some impacts, and that impact happened over about 6 to 8 weeks.
It seems like in this work that we do, a lot of times what we're doing, I was going to attribute this to a traditional model, but I don't think it's really a model. I think it's what we fall into, moving from crisis to crisis with people. Oh, we've got this horrible crisis. We've got to resolve this crisis. And then we relax and don't do anything. And then, we mark the next crisis that comes up. What we're trying to do here is back up and look at what are the foundations for avoiding crisis? What are the things that we can get people engaged in to prevent those crises from occurring and give them a life worth living? And it seems like that's a lot of what you're trying to get across here, Dr. Kelly.
Absolutely, absolutely. And if you think about, I mean, for me, the pandemic was really crystallizing in terms of how important this is because you could see it in yourself, right? Like if you thought about how you were feeling and for me, I remember feeling very blessed because we do live in a neighborhood. So like we have a yard, right? Like we're not in a small apartment. We could go walk in the neighborhood and have a little bit of interaction because you could do it from afar, right? You could wave to the neighbors or talk across driveways. And so when you really think of when you're at your best, right, there's no reason for us to think that that's different for folks with disabilities, but they may need help or we may be getting in their way, right? Most of us, if we know these things about ourselves and what we need, we can do them ourselves and people are not getting in our way. But a lot of the folks we support, they're going to need help to do it and or someone thinks that they don't have permission, right, to let them do it for some reason or another. And so it's really activating that different way of thinking and making sure that we are saying none of the other stuff we're going to do with people, even when they do need formal treatment, is going to work if we don't have this foundation here. The foundation it's like building a house with no foundation, right? And you're right, we do. We have a very reactive system. I often think of our DD systems as a firehouse where we send everyone to fight the fire. And like no one is staying back at the house going, okay, how do we make sure no more fires start?
Yeah.
Right? So
Yeah,
that's,
absolutely.
yeah.
Well, I think a lot of times we think, well, these things are great, but they're not relevant to this bad situation we're dealing with right now. We'll get to that later, but then we don't get to it. We do have one comment so far from Margaret Newberry Jones, was one of our previous presenters on here, and she's made a really apt comment here. Babs, you want to tell us about her comment?
Yeah, she says, thank you for stating that behavior plans are about the individual changing when in fact their supports and the folks around them usually need to change.
Yeah.
That's couldn't be more truly stated there.
Yeah, it's really a plan for the rest of us, right? When we
Yes.
do that. And that was, it's great that you pointed that comment out now, Bruce, because actually this next slide is really a set of tips that we've put together. So many of our clinicians started telling me once we started looking at the wellness guide, like I feel like every time I've written a plan, if I have felt that I needed to do, to have a written plan, I'm just telling the staff like what to do and what not to do to sort of make sure the person has a good day or to get out of their way. And it was much more rooted in the wellness principles. So in addition to doing the wellness guide, we are really shifting, and we're actually about to launch a DSP curriculum on wellness that will include these routine supports. So basically saying, if you think about the functions we often put in find in functional behavior assessments, and it actually is linked to wellness areas if you think about it, right? And it's not that it's not that it's impossible for any of us with or without disabilities to do something that's maybe not the most functional to sort of get something that matters to us. But isn't it important that we make sure you have the basic access to the important things in life first? We don't need to be sort of making you sort of earn that or tight, right? So what we've said is we want to move to a situation where no one needs a plan for this, right? We just start teaching staff. Your job is to do these things. You should build constructive, supportive relationships with the people and help them build those relationships. Provide routine social activities with them, respect their choices, and assure connections with the people who matter. And you'll notice some of the stuff's in red. It's because those are really linked to things you think of being trauma informed, right? Making sure people are connected to the people that matter the most to them and for whom they feel safe, right? There are similar things when you think about things that, we do at work and at school. And, one of my pet peeves is when people talk about escape and noncompliance, right? Because I always think like I was noncompliant today, right? Like my husband and I both work for the state and we both work from home, right? So I bet if I walked out of my office right now and I said to him, did I do anything today that you wish I wouldn't have done, right? or that you wish I would have done differently? He's gonna be like, yeah, like, of course, right? But we don't have that sort of imposed on us. And so, really looking at, are we paying attention to how somebody wants to spend their time? Are we making sure that the things we're talking about when we use words like compliance are like essential? They're really important things all of us need to do, right? Making sure that when we're supporting someone's spiritual wellness, we don't think we're doing that because the staff is just bringing someone to their church, right? Instead of really understanding, how does someone see spirituality? When we're looking at physical health, making sure we know what are the signs that someone isn't feeling well. Making sure we allow them balance in the things they like and the healthy choices they need to make, because healthy choices are easier to sustain if you also are able to have some things that matter to you, right? If we think of ourselves with diet and exercise, almost none of us are perfect all of the time, right? We get to cheat a little bit, right? And then in emotional wellness, are we really looking at someone's, how do they relax? What makes them calm? How do they communicate feelings? And are we paying attention to that? All of those sorts of things are really important. And so we're really shifting to, this is just routine supports. And so as clinicians, we are also trying to be mindful that if these are the recommendations we make, we are trying to make it in a different format than in a behavior plan, so that we are sending the message to the supporters that person has. This is just stuff you should do all the time. You should build this into this person's wellness guide if they have one. You should build it into their day-to-day instructions, anything like that, because this needs to stay, right? This is not just something for you to do while I'm here. So I saw two questions flash. that were brief.
Yes,
Um,
yes, we do have a couple of questions. Babs, you want to
Yep.
cover these questions?
One of them is occupational therapy a part of this program?
So I do have an entire allied health team that works for me. So we have, I think, 5 physical therapists across the state. We have an occupational therapy department of 6 or 7 OTs. I can't count them that quickly in my head, and 3 OT techs. And we have 4 speech language pathologists across the state and a registered dietitian. So we do have those individuals involved in what we do. They don't get involved in every single person in the waiver, right? If they don't need those adaptations, but we do have them involved in the work that we do and all that we develop.
Yeah, I mean, if you're thinking about wellness, occupational therapy is going to be a part of that. And, especially you were talking about pain as a potential motivating factor. This is one of the interventions we have to address pain issues for people. So clearly, I think occupational therapy is a part of it. And you're reinforcing, I think, something that NAD really talks a lot about, which is interdisciplinary practice. So important.
Well, and I call my allied health team, they're like the unsung heroes, right? Because so I mentioned earlier, my sister has a disability. She has very significant physical and mobility issues. So I have a personal love and appreciation for both the OTs, PTs, and quite frankly, the speech pathologists that we have encountered. But so often, to the point you made, Bruce, about pain and discomfort, those are, if someone isn't also being aggressive or self-injurious or emotionally responsive, then those can be the silent struggles that people have that people are not paying attention to. And it makes such a huge difference in someone's quality of life, their comfort, and then what they can do on a day-to-day basis independently.
Good stuff. Did we have another
Yes,
question?
Dr. Kelly, the other question was, will this information be available in print format? Are you comfortable with me making these slides available?
You absolutely can. And on the last slide, there's a QR code that will take you to a little Padlet site that you can access anytime you want and use any of these. And I always tell people you can use them as they are. You also can adapt them in whatever way works for you, right? These are not some fancy copyrighted, thing that you have to do exactly the way I think it works, for me. They're really just guides to help us think about how we can support people with disabilities and support the people who support them. So yes. So we mentioned some broader positive psychology practices. And so kind of to take the wellness piece to a different level, we've also done some work in, I didn't want to muck up the slides too much, but you will have access to both this guide. There is also another version that we did that we call our daily game plan. But we took some of the work. So one of the things that I draw on, I mentioned I am a big fan of Dr. Tomasulo. So he wrote a book in the midst of the pandemic. Ironically, it came out called Learned Hopefulness. And I keep it with me. It's on my computer, on my Kindle app. But it really walks through some of the core positive psychology practices that can help to activate the things that they found in that 20% of people who don't relapse. And it's things like mini gratitude moments. It's things like knowing someone's strengths and sort of strength spotting and activating those strengths. Relationship building and things like that. And so what we did is we thought, okay, if we really think about what we train staff to do, right, and the things that we often as clinicians give recommendations about, we really often say, these are all the bad things that might happen. And here's what you do to avoid the bad things, and here's what you do when they happen. We want to shift to saying, here's the good stuff that could happen. And here are the strengths that this person has. And here's how you spot those strengths and help them use them, right? So in doing that, we thought, well, how do we help staff sort of have a better day? So the larger daily game plan that you'll be able to access at the link that I'm going to give you actually walks a direct care staff member through what would you do in any shift. It can be used just as a training guide. It could also be morphed into the daily progress note for that person, where we're actually now capturing positive things that happened and then learning from what works and what doesn't, so we support the person better. But this one is also one where we use this in the pandemic, where when somebody's not doing so well, right? Because you can't, wellness is important during those times, and these positive practices are important, but you're a little bit, if you're in distress, right, you're a little bit less able, right, to do some things. So the first thing that we want is to make sure that the folks who are with the person learn that it's actually okay to not be okay, right? Sometimes I think we expect people with disabilities to be more resilient than the rest of us.
Yes, no question about it. That is such a ridiculous phenomenon that occurs every day.
Yeah, I always think like I have some really off days, right? Like, I mean, hopefully, not everyone that has to encounter me sees it, but if you think about it, the people you are most comfortable with, they do see it, right? That's who we share it with. So we send all kind of messages that like it's not okay to not be okay. So trying to teach the staff and coach them, it's okay for the person not to be okay. So maybe you just check in with them. How are they feeling today? And it's okay if they're not feeling great. And don't immediately start trying to rebut that, right?
Yeah, golly.
I think one of the things, and it sort of launches off that, is I don't understand why they didn't pick this up. We've gone through this. We've worked on this skill together.
Yes.
Why isn't this skill being applied? I just don't understand. In the meantime, I come home after a bad day and eat a bag of cookies. I know a different skill. So
I don't want to tell you how many pounds I put on during the pandemic, right? Because sometimes the only thing that was kind of sort of fun in the day was whatever you were going to sort of eat in front of the TV screen that night, you know?
watch it eat. Mhm.
The other part of it, we all get good at hiding this stuff, and people with disabilities are being observed all the time.
Yes.
I know.
No room for
Think about your worst moment, right? And like, would you want, people to be like sort of observing that and writing it down for folks, then helping them to learn how to sort of supportively help the person change the channel, right? So if I'm anxious, what can I do, right? We worked with people during the storms in particular and the pandemic, right? If I'm anxious, maybe I should turn the channel, right? Literally, like turn the news off, right? Like if I'm worried about my mom, I can call her. If I'm, things like that. So what are some things they can do that will help a little bit for that day? Mini gratitude moments. So a recognition that when you're not in your best frame of mind and you're struggling emotionally, trying to do the fancy, write down 3 things at the beginning and the end of each day is harder. But you could find one small thing that you're grateful for. What are small goals? So like adjusting those goals. What do you want to do that's going to make you feel good or well today or relax, right? Like what is something that's soothing that person could do? Who do you want to connect with? Right. So who is it most important? One of the things I always say to folks is I see red when people start thinking like I've literally seen plans where people say, well, if you do these things, then you can call your mom tonight. I mean, I don't know about y'all, but I can be awful today and I can still call my mama tonight. Right. Like I never have to earn that. So making sure people understand those most important connections, people that the person feels safe with, or they need to be there. What one small thing that you could do that day to move things forward? There's a story in Dr. Tomasulo's book that I love where he's working with an individual with depression and she's really let her house go and she feels overwhelmed and she can't clean anything. And he says, why don't you just clean one dish? Right? And she ends up cleaning her whole kitchen that night because all she focused on was one dish and then one dish and then one dish, right? And then celebrating. So how do we kind of acknowledge what went well? And then how do we learn, including learning, what does help, right? What helps you feel best when you're struggling? So again, we've used this, we've piloted it with some great success. Our clinicians during the pandemic and the storms were able, even with new individuals that they had never before treated, were able to use these guides from afar, right, virtually via telehealth. And 98% of the folks that we engaged with did not go to the hospital, did not go to the emergency room, and did not end up in any sort of other institutional setting, despite everything, right, that was challenging. We used this along with the wellness guide with that provider I mentioned previously and the 8 individuals they were struggling with. They even used this with a set of 3 roommates. and only one of the roommates was identified as someone that they thought might need some professional treatment, but they used it with all 3 roommates, and it improved the roommate relationships because people were talking more and listening, and the staff understood what worked best for each of the 3 individuals. So that was really interesting. I think this is my last tool that I was going to share real quickly, is just a tool. Then how do we build this into our progress and our outcomes, right? Like, what is it that we is success, right? So often we're looking at, did the bad stuff go away? And we adapted this. It was, I went to a training in the early days of the pandemic, and they presented this. And it used a lot more complicated language, right? It was really an employee version that they were asking us to kind of think about our well-being, right, during the pandemic. And we adapted it with some language that was really a little bit simpler for us to use with staff and families. And it dawned on me as we did it that at best, often we settle for people coping well, right? When you get this and you read the stuff in the resilient and the thriving, we don't nudge sort of for that, right? So really, if the work we're doing is good, and if we want people to be less prone to relapses and problems, we need them to be more connected, to be developing skills, to be working and having something meaningful to do in whatever way they can, to have relationships that aren't paid, right? And to be learning new things and discovering new things. And those are the kinds of things you see in the resilient and thriving category. So as clinicians, not only can we use something like this as we're looking at how is someone doing and making progress, in addition to maybe monitoring or their changes in sort of the actual symptoms we're looking at, but this can be used by a provider, by a family, right? Like by anybody, do you see changes in terms of how this person is sort of connected to all these various wellness things? And this is, so Babs just put it in the chat, but these tools are available. There is also a clinician visit form that you will see here. I didn't throw that in here, but I wanted to share it with you. We built that so that it's not just focused on the problems, but also it guides provision of any changes in the person's life that might be affecting wellness, and hopefully guides us as clinicians to make recommendations that start with, are there any wellness considerations, and then go to other things.
I'm so proud of myself. I made that QR code work. I was able to get right to the toolkit with that.
Yeah,
This is amazing. Great stuff, Dr. Kelly. So thankful to you for coming on with us today. Unfortunately, we don't have much time for questions now, because we rudely interrupted you with them all the way along, but it was very good stuff. And I hope people will look at these tools and utilize them, because they're quite good, and I think lead you in a different direction than we typically go. Another comment that was made here by Margaret Newberry-Jones, Wolf Wolfensberger talked a lot about this stuff back in the 60s and 70s, but we're still trying to master this, especially about people living in a fishbowl and being observed all the time. So, but thank you so much, Dr. Kelly, for being here with us today.
Thank you all for inviting me. It was really fun.
Yeah, and we need to do this again. If you come back 5 times, you become part of our 5-timers club, and we give you a figurative green jacket for that. So
we do.
I'm game. I'm game, Bruce.
Please feel free to join us anytime. Actually, we do it every week, as I said before, at 12:30 Central. Thank you to my co-host Juanita St. Croix, and of course our producer Babs Tierno. And we will see you again next week on the Clinical Consultation Network. So long, everybody.
Thank you, Bruce.
Thank y'all.